So good evening, everybody. Welcome to episode 15 of the Hope for Healing video podcast. I'm Dr. John Stracks. I'm joining you from my office here in Chicago. I'm here this evening with Evelyn Hecht, who's a pelvic physical therapist in New York. And before I introduce Evelyn, let me tell you just a little bit about Hope for Healing. It's a joint effort between the people at the Curable app and me. And for those of you who aren't familiar with one or the other, I am a physician in the Chicago area who focuses on the reduction and elimination of physical symptoms using mind-body medicine methods. Curable is an amazing app focused on that same goal. And we've been working together since their inception about 6 years ago now. A couple of notes before we get started. First of all, Evelyn and I will be discussing her work and her insights about healing pelvic pain for about 45-50 minutes probably, and then we'll be taking questions after that. If you have a question at any point during the broadcast, type it into the Q&A feed if you're with us here on Zoom, or into the chat on the Facebook feed. And Curable is monitoring both of those for us, and they'll get the questions to us, and we'll do our best to answer as many questions as we can. Secondly, I want you to know that I have expanded my telehealth practice significantly during the COVID-19 pandemic, and I'm working to sustain that once the pandemic is over. So no matter where you are, if you're feeling stuck with your symptoms, please feel free to reach out to my office at www.drstracks.com, and my staff will be in touch about how to talk with me directly about what you're experiencing. And lastly, just want to spend a minute talking about the framework of how we think about healing from chronic pain. So many of you know what we're discussing is mind-body medicine, meaning that our bodies can express for us what's going on in our minds or in our lives. And I think that that's universal. It doesn't make us sick. It doesn't make us bad. It just makes us human. And it only becomes, quote, bad if you enter into a medical system that doesn't understand this and treats all physical symptoms as if they have physical origins. I think human beings have always expressed in our bodies what's going on in our lives, and we always will. And so our goal, my goal, Evelyn's goal, all the other practitioners in this space, our goal is to help you learn what to do about that so it's no longer physically uncomfortable or painful for you. With that, let me introduce Evelyn Hecht. Evelyn is a master clinician of pelvic physical therapy and a certified biopsychosocial chronic pain rehabilitation practitioner. For over 25 years, she's led a team of pelvic physical therapists at her practice in New York City, guiding thousands of men and women toward optimum pelvic health. In addition, Evelyn has designed a robust pelvic health curriculum for New York University and Stony Brook University, as well as doing ongoing research in the women's health field. We oftentimes hear from clients who don't realize how prevalent pelvic pain issues are until after they've talked with one of us, because people don't always talk about that aspect of chronic pain the way they might about, say, back pain or migraines. And so I'm so glad to talk with Evelyn tonight, not least because of her refreshingly direct and empathic way of talking about pelvic pain. And I hope that everybody who's listening, whether you have pelvic pain or any other kind of pain syndrome or symptoms, that you find inspiration in our belief that pelvic floors and pelvic pain are a reflection of our state of mind. So Evelyn, I am delighted to have you here. Welcome. Thanks so much. And welcome to Hope for Healing.
So thrilled to be invited and to talk with you, John. I'm really excited to share our knowledge with the viewers.
Great. So thanks for being here. As you and I talked, we had 2 feet of snow over the weekend in Chicago, but I have heard it was not so bad in New York. Is that correct?
It's like melted. Yesterday was spring, and maybe tomorrow will be winter again. So yeah, kind of weird, but gotta go with the flow, you know?
Yeah. And I had a class last night. We do classes on a weekly basis, and we have people from all over the place. And so half of us were like I was working from home for 2 days, and half of us were trying to shovel out from 2 or more feet of snow. And then other people were basking in the 70-degree weather in California. It just was not fair.
Amazing.
So anyways, I'm so glad that you're here, and I'm super excited to talk about this particular topic. Can you tell us a little bit about how you got started in this particular field of pelvic physical therapy?
Sure. Well, I think I grew up in Beirut, Lebanon, Norway, and Brooklyn. And so my childhood saw such a wide varieties of the way women dress, how they felt about their bodies. I was always very curious about that. And because I had lived in these different cultures, when I was now a physical therapist and worked at a pretty international hospital in New York City, where a lot of international patients would come in to be treated. And I would consistently get questions as a young physical therapist, like 20. Evelyn, I cannot have sex with my husband. Oh, I don't know if I can have children. Or someone asked me about, I'm having difficulty with going to the bathroom. I can't go, it takes me hours. I have so many people ask me these questions, and I didn't know anything about pelvic because it wasn't taught in our school yet. And when I asked my colleagues about, did they have these questions, all of them looked at me like, never, nobody had ever asked them. So I thought, wow, there must be something about me that's eliciting these embarrassing questions, and I handled them with ease. I wasn't at all, felt abhorrent or felt reject or felt like disgusted about these questions. I felt real empathy for these women, mostly women were asking me questions, some men, about these people that were suffering. And because I didn't know much about pelvic issues or what it was, I said, well, there are muscles everywhere in the body. There's nerves, there's function, so let's look into it. And really, in looking into it, I started to become more excited about how can we help, and tried a few techniques on my patients and saw that it helped them. And so from there, it's been just an amazing journey, learning about the function of the pelvis, the way it works, and how it relates to the way our brain and body work together.
And so when you think about that, so your career, it spans 25 or more years now. When you think about how you define pelvic physical therapy, and so for the people who are listening at home, what kind of conditions does that encompass, and what kinds of symptoms do you end up treating for people?
Sure. So really the pelvic condition involves anything from really under your diaphragm or at your navel, if you want to call it your belly button, down towards the bottom of your pelvis. So issues with digestion, with elimination, reproductive health, though that's a specialized, even a super specialized area, vaginal pain, sitting issues, constipation, anything with IBS, interstitial cystitis, bowel, bladder, sexual function, that incorporates pelvic floor, pelvic physical therapy.
And I think a lot of people think of it in terms of the sexual function and that part of it, but you're saying there's a lot more to it than that. There's a lot of GI issues that are caused by what's going on in the pelvis, urinary issues, and
yes,
and probably some others as well, musculoskeletal
yes,
also.
definitely.
So a lot of physical therapists obviously are very steeped in the physical world, and more people in your field are understanding the psychological component. How did you first learn that the brain and the pelvis were connected, and how did that start to come about in your practice?
I love that question. As I was doing the work, I have always been interested in the body mind naturally. So I would do breathing techniques myself and meditation. And I would broach the subject to patients, but it wasn't, quote, scientifically proven, unquote. And so I felt a little bit out of my league, but I would play with it with a couple of my patients about incorporating some of these techniques. The real reason why I jumped into it more was because I'm a little bit of a science geek. I like to read about the evidence of science. I love information about the brain and nervous system. And, 60% of my patients would do really well with the classic pelvic manual therapy and movement work that I provided. not saying I'm a fantastic physical therapist, but I did pretty well, and they did really well, and they bought into, or they did the work they had to do. But why did 30 to 40% of patients not do well? Like, it always perplexed me as to, that's too many people not doing well. And it wasn't something I had to blame the patient or even blame me on. There's something, we're missing something. So around that same time where I was just questioning, why is there such a disconnect? Why aren't all patients at least making some good gains? Then the pain neuroscience and the information about the biopsychosocial approach to healing came out about 15 years ago, 10, 15 years ago. And so I started to introduce that to my patients. So then it became educational about what's pain, why might you have it? And I, of course, was met with a lot of, oh, I've never heard this. My doctor has never said this to me. I don't believe this. Some of them. Other people were like, really? I've never heard that before. So it had a different take. But being in the world of pelvic physical therapy, when I first started it, nobody was doing the work, not in New York City. So I'm used to sort of being a little bit on the forefront. Not that I'm trying to be, I am in that way. So, and I knew I was going to get, flack from that. But the people that did start to accept and want to listen to, and maybe let's try some of these techniques, they started to do way better than now it was like 70% of patients were really doing well. And I started to incorporate more of the mind work along with the physical work. It wasn't one or the other. It was a combination. And then it really saw more people doing well. And so it was through the channels of learning and of playing, and then feeling more confident as I got the science. Once I got the science behind it, the science of breathing, the science of mindfulness, and the science of manual therapy, science of movement, the new science, then I felt really more confident in the way I approached patients, and the patients responded.
Yeah, and it's super refreshing too. Like before we started, you and I were talking a little bit about people's experience and just how often people tell me, and probably you, that they feel kind of blamed when they don't get better, or people sort of imply that they're not trying hard enough. And so nice that you were able to recognize that it was nothing about what people were or weren't doing. There was just this aspect that wasn't in your awareness yet. It's super refreshing to hear that.
No judging.
Yeah.
Everybody's healing process, as you know, John, it's a healing process, and there's no time. Okay, you're at a track meet. Okay, time is off. Run that 100 yards in under 7 seconds. No, everybody has their own path.
I was talking to a patient yesterday, same idea. We sort of got through towards the end. She's like, so you don't think I'm crazy? I was like, no, we have a rule here. Nobody is crazy. Everybody is just trying to figure out how to find their way through this maze of symptoms and pain and the medical system. Right. And so nobody who comes to see us is crazy, but the system makes you feel like you are.
Yes, yes. One of the things that I love to teach patients about the brain is that the longer somebody has been in distress, in pain, in dysfunction, the longer you are in that feeling, the more that the executive brain, the prefrontal cortex, the cells atrophy. But with practice and retraining skills, the cells grow back and better neuronal pathways are taken over. So when people say to me, I feel brain fog and crazy, I says, totally. If you lose some of your prefrontal cortex gray matter cells, you're going to feel brain fog in exactly the way you feel. So it's understandable. And that was really helping many of my patients feel less crazy, because there was actual MRI information that proved that. So a sense of feeling crazy does not mean one is. It just means that the brain is not snappy as well as it could be.
Absolutely. Absolutely. So I want to spend a few minutes talking about what happens when you see patients. And so starting with, say, an intake evaluation for a new patient, What kinds of things are you looking for? What are you asking? What are you testing out when you meet somebody for the first time?
Oh, that's awesome. Well, before we see a patient, we'll send them a classic intake form. And what we've started to do is send things like a pain catastrophization scale, a PANAS scores, which is a positive affect or negative affect, how positive one tends to be or how negative one tends to be. So these are actual wonderful, great questionnaires that have been tested, that are user and reuser for patients to give an insight into the person's way of thinking. So we incorporate that at the get-go. So it's not just like, okay, we're going to take a look at your obturator internus muscle or the way that you're able to contract your pelvic floor and relax. It's a combination of do you have a tendency to do a little catastrophization of pain? And that's measured by this PCS score. So the work is started by them understanding we're going to look at as much at everything as possible. And then the information there's a lot of listening that will wait and will listen to the patient to describe their symptoms. I've learned that research has shown that a lot of health practitioners, they will butt in to get their questions in within, I think, 5-6 seconds.
5 to 7 seconds is the
7
average
seconds.
time that a clinician will
So,
interrupt.
yeah, right. So in 7 seconds, if the practitioner is butting in, what I've tried to do is I don't take notes. We look at a patient and we'll let them speak as long as they need to. And most people don't spend a full 30 minutes talking about the symptoms. I mean, most people are pretty good at themselves at being able to talk about how they're feeling, and probably within, I don't know, maybe 10 minutes.
Yeah.
And right?
Yeah, no, when I worked at the hospital, I would get medical students in the clinic periodically, and they'd watch me in an intake interview, and they would comment on that they had never seen another physician be that silent for that long. And frequently we were talking like 8 to 10 minutes. It was certainly not 30 to 60 minutes of people talking. And because that compares to the 5 to 7 seconds, which has been shown in multiple studies.
Okay. So that's a big part of establishing a therapeutic alliance, is to listen to what the patient is saying. So we can really, patients know what's going on with them. We can interpret, as health professionals, we can interpret the information that the patient's giving us because it's valid and amazingly important information. So that's the aspect of how we first assess a patient, is by first listening, getting their intake forms that we look at prior to them coming in. And then we'll start doing, with their permission, we always give patients information about how we're going to assess their pelvis. So we'll show them a model of the pelvis. We always say, we're going to ask you permission. And if we're able to do this next phase of our examination, we will. If you don't feel comfortable, we won't. There's no pressure. We want to start and move as comfortably as you, the patient, feels. Our interest is to assess a couple of things. We'll assess, first of all, how is I'll talk about she, but both, she or he breathing. A lot of the pelvic floor, which is so cool, it moves along with diaphragm, your breathing muscle, the diaphragm underneath your ribs. As you inhale, the diaphragm lowers, right? The diaphragm lowers to allow your lungs to fill. Well, the pelvic floor, the pelvic diaphragm also subtly lowers as well. And when you exhale, the diaphragm raises back up to its upward resting dome position, and so does the pelvic floor. And now a lot of people in chronic distress or dysfunction are not breathing well, or they can't do a deep diaphragmatic breath. And because we're breathing like 17,000 times a day, is that right? Maybe more. We're breathing many, many thousands of times a day. If we're incorporating a few breaths that are deep enough that allow the pelvis to move, that allows a pelvic floor to really be in a quieter place versus the typical high tone, tense, nervous pelvic floor. So we look at breath. We look at gentle movement. Can the person move, arch their back and flex around their back? A lot of people are very stiff. A lot of people have told me, I don't really have a sense of feeling really well between just underneath my chest region and on top of my hips. Like I feel like it's a dead zone. Well, let's see if we can allow your body. Can you move? Are you coordinated? So we're just observing. So we look at movement, and then with their permission, we'll start doing the pelvic floor muscle exam. So I'm not sure if you need me to go into all this, but we look at the external vaginal region. This is for women, at the perineal area, and we ask them to do some contraction. Does the area move or not? We ask if they can contract. Can they relax? Does the muscles relax right away, or is there a holding and I'm not so sure? And a bearing down. Is there any excursion as to a bear down? Most women that we see with high toned or tense pelvic floor muscles have very minimal ability to bear down, which can contribute to some of the patient's symptoms of constipation or vaginismus, that's painful intimacy. And the pelvic floor itself, we'd like to palpate or feel. Your muscles at rest should have a nice give, like a softness. And everything is done without creating any pain. We're not interested in that because you're already feeling pain. We don't want to aggravate the nervous system. We don't want to trigger the brain to get worried and send more pain. So we're about, what can your body tolerate? Is it sensitive enough or less sensitive to allow me to move the tissues? And we also measure its strength. Does it have a good ability to hold? Can it relax? Does it go back into a lower resting rate? So we get a lot of information from that conversation, and then just the little exam I just mentioned.
And I would assume that patients are sort of all over the map in terms of how comfortable they are with the exam. I'm sure that some it doesn't bother them at all. Some it's probably uncomfortable or embarrassing. Do you get many comments on that in terms of people sort of sharing with you when they're uncomfortable with what you're doing, or the opposite, that they are pleasantly surprised at how comfortable it is?
You know, we're always watching our patients' faces. And you're like, just move like that. Like I'm watching you. Yes, there are a variety of responses about patients. I'm talking about women right here. Women feeling comfortable. Most people say, "Oh, please do what you want." I've been to so many different practitioner. You know, I just want to see, can this be helped? I haven't met too many women that are so fearful of allowing me to work on their pelvis. We drape people with beautiful sarongs, so we don't make, it's not like and we don't have people really expose themselves for any length of time. In fact, we ask people to help lift the sarong, so they're giving us permission to assess their pelvic floor, to observe the pelvic floor. So we're very mindful about privacy. All good physical therapists, pelvic physical therapists, do treatments in private closed door rooms.
Yeah.
Yeah.
And so you do the initial assessment, and then the next step obviously is to figure out what you can do that's going to help people. And so how do you think through that aspect? How do you decide what you're going to focus on and how you're going to get started?
That's awesome. Well, a lot of people who come to a pelvic physical therapist with issues, they have not had it for a week. It's most of the time for years. Maybe they've had it, maybe they've had it like 6 months, but that's already chronic. I'm going to call it persistent. That's already too long of a period of time. After 3 months, it's gotten into the brain and nervous system. That's just the way we roll. That's the way our bodies are, the brain is. So I'm already educating them at the first session a little bit about, what, it's gotten by the 3rd or 4th month, most people with constipation, I try not to use the word chronic because it means it never gets better. I use the word persistent. Most people with persistent constipation or vaginal pain or abdominal discomfort, your nervous system and brain is now going to be always on the high alert for any kind of danger, any kind of threat. So even if you had, you know, an argument with a colleague, a work colleague, or an issue with one of your children just acting up again, or you're worried about, I'm not making enough money, you know, this month. All of those are seen as threats to you, and the brain has gotten so like a helicopter parent, hovering. Okay, I got to send a protection. And the best way the brain knows, and there's nothing wrong about that, is the best way the brain knows to send the protection is to send pain signals, or signals of burning, or signals of distress. So within the first session, we've started to talk about how part of our work together will be to start to lower the sensitivity of that nervous system and brain. And the first thing we'll do is breathing. I'll also will do teach people about how to do a guided body scan. Lots of simple at-home techniques that they can do to start their day, or to intermingle, intersperse throughout their day, to lower the high level of nervousness and tension, and just reset and just reset and just allow the reset to come back, so they're not in that constant whirling upward of their symptoms.
And you know, what you said earlier, that how the body tries to express these things. So I say that a lot to people, that like our body speaks really clearly, it just doesn't speak very well in English. And so we need to start to interpret what our body's saying so that it comes through, and we know not that our body necessarily is mad about this or mad about that, but that we might be worried about how much money is coming in, or we might be scared about a conversation that we need to have. And so the language that I frequently use is that the pain is not the enemy. Our bodies are not out to get us. They're really trying to give us feedback about what's going on in the world around us. But the language that it uses isn't always one that we recognize, at least at first.
Mm-hmm. And we could learn. So part of the work that we do, John, as well as the way my practice works, is that we try to teach the patient, how can we create a language that can be calming, and then that can create safety, and that can encourage more of the happy chemicals, the dopamines, the endorphins for the brain to send, versus those pain chemicals. So while one person is feeling pain, what can she do to start to mitigate that and calm that? The more that there is a conversation or a language of, I can calm this down, or I hear you, but I'm in a safe place. I'm going to do a guided body scan to make my body feel even more comfortable. And my nervous system and brain also says, hey, that feels good. So working together with that information that as you said, John, that the pain is expressing an information to the person.
Do you have a favorite breathing technique that you like to teach people at the beginning?
Yeah, I teach a few different techniques. Really, the first and easiest one that anybody can do is the diaphragmatic breathing. And that's really and especially with the pelvic world, now that you know that as you inhale, deeply inhale, you're also are going to have a widening, a lowering of the pelvic floor muscles. And so therefore, you're going to have a decreased tension of the pelvic floor. So whether it be on their back with their knees bent, or side lying, or sitting in a chair, whatever's comfortable, to do 3 to 5. Usually I'll have people inhale for a count of 4 seconds. And those seconds are 1, 1,000, 2, 1,000 to 4. And if they can, at the end of that inhale, hold that inhalation for 4. Again, 1, 1,000, 2, 1,000, and then slowly exhale for a double count of 8. So that, now a lot of people, when they start, it's way too long. So I'll just modify it. Maybe inhale for a count of 2, don't hold it, and exhale for a count of 4. But just start that process of slower breathing and that will stimulate the parasympathetic, that rest and digest nervous system to be activated. You know, in our bodies, we have an autonomic nervous system that allows us to digest, to sleep, to have sex. So if people are in chronic distress or pain, studies have shown that there's an elevation of one of the aspects of the autonomic nervous system called the sympathetic nervous system. And they're not the other, the parasympathetic, which is the calm, is not activated so well. So the more that a person who's in chronic persistent distress can do activities that will elevate the parasympathetic nervous system, the less that the sympathetic nervous system, the fight or flight, the worry, the scared, is active. So it's either one or the other when you are in your day-to-day life. So the more that it can be done that way, breathing technique is one of them.
And so, and you start to teach these types of exercises to people and people practice. And so then as you work with people over time, what does that look like? What are you doing with them? How much is on their own? How much is together with you or your staff in their office? What happens in the after the initial assessment?
Very good. So
recommendations?
So part of the initial assessment, along with the assessment of the tissues, because we do look at that, and a start of the educational of the mind and brain on teaching of the breathing, we'll start doing some stretching to the area that might be sensitive. So if it's on the abdominal, lower abdomen region, if it's on the inner thigh, if it's on the pelvic floor muscles themselves, part of our therapy then will be to apply some of the manual therapies. And we teach this is to help your nervous system become less sensitive to touch. Rather than we're going to break up trigger points. We're going to really, roll everything out to smooth. It's really to help your nervous system become less nervous. It's also gentle manual therapy, and just whatever manual therapy feels good to one. It helps increase the pro-inflammatory cytokinins. It decreases the other way. It basically decreases
the inflammatory cytokines.
Positive inflammation, exactly. It's cytokinins versus the bad ones. It decreases that. So it allows for also a better release of some of those happy chemicals. There's a lot of things that occur with manual therapy. So we use manual therapy to really allow all these nervous system responses to occur, the brain and nervous system, and to also let the tissue, whatever muscles, the deep gluteal muscles, the piriformis, the hip rotators, all those muscles, we'd like them to feel less sensitive and allow it to be moved. So manual therapy, and also exercises. Now, exercise as well has a huge amount of benefit to the body. We always educate patients about what that is, and we slowly build upon exercises. One might be just to stretch the inner thighs and to release a lot of the natural holding that women in persistent pelvic pain have, is they grip and hold tight. Bladder pain or people afraid of leaking will also, without realizing it, just grip those inner thigh muscles. So we want this inner thigh muscle to be soft and more relaxed. Muscles shouldn't be in a holding tight state on and on forever. It's not healthy for that. So our work, manual movement, and the incorporating of mind exercises has found to be a beautiful mix for our patients.
Nice. And so I'm sure, as you said, just a lot of the people who are listening have had these symptoms for 6 months or 3 years or 15 years. And so some of them are listening and thinking like, okay, I mean, I do that already. Like I've gone to the physical therapist and I do my relaxation exercises and I manage the stress and the pain is not getting better. And so what are some of the things that you think about for people who feel like they're stuck? And these may be people who are seeing you or not seeing you, but people who feel like I'm working and working and working. What are some areas that you think about that might offer some clues into getting people unstuck?
Yes. Well, one of the things when people tell me that, I'll ask them specifically, what are the activities that you're, excuse me, that you might be doing, that you are trying to do, and you feel pain. I'll give an example. One woman I worked with said, every time I bend forward to open my cupboard in my kitchen, I have searing back pain. And we discussed about when this started and what some of the conversations she may have heard about her back. And she did say, and you probably know this, John, that she heard one or two of her physicians saying, and no negative on physicians, I love physicians. They said, don't bend forward because you'll slip more discs. And I said, well, that's not true. Your disc, if discs do herniate, the reasons why, the new science is showing the reasons why people are sensitive to that lower back is because the nervous system around that area has become hypersensitive. So it's not another slip disc, is that the nervous system around that area has become really hyped up. So let's do something. Bending forward. How about if I had you lie on your back and you brought your knees up to your chest and you were in that position? Can you do that? Yeah, that's pretty good. I said, you know, this position is called lumbar flexion. It's the same position you would have taken if you would have bent forward, maybe not to the full extreme. And they were like, oh. And what I asked them to do is to acknowledge conscientiously, is this a position that will cause slip discs? Or is this a dangerous, will it cause some tissue tearing in this position? Knees on, lie on your back, knees up to your chest. No. So that's good. Okay, let's do something else. Then we'll go to another position. Come sit in a chair, and then let's have you bend your head forward and roll your shoulders forward, and let's have you roll down as if you want to bring your head between your thighs. How do you feel about that? I'm a little nervous. Okay, let's come back up. Let's go halfway. How does this feel? What are you worrying about? Or do you think this might be a position that creates some tearing and disc pulling? Yeah, but it doesn't make sense. So it's a step-by-step process. So that's one thing we do. We'll break it down into steps. The second thing we'll do with patients is using their imagination. It's called graded motor imagery or visualization. Now, a lot of athletes, when they train, like a basketball player, if they're going to train, they have to go physically train. There's a lot of mental training that an elite athlete will do. Yes. So if they're at the 3-point shot and they're going to visualize themselves standing at that line, 3-point line, they're visualizing themselves standing there. They're actually going through a mental process of how they are breathing when they're standing there, how the ball is dribbled, how many bounces they're going to do, then how they're going to grab onto the basketball. Then they watch themselves move upward so that the ball now is arched up and goes over into the basket. They watch the whole thing in their brain. What that does is it stimulates, activates the neurons on our sensory motor cortex, which is the virtual map of the body on your brain. So what we're doing here, so I'm going to take it down to somebody in pain, or take it to a situation with somebody in pain. I can't sit for more than 5 minutes. You know, I'm a therapist and I can't sit more than 5 minutes. How am I going to do it? So we'll start to visualize them sitting, and they're not sitting, they're in a different position. And so we'll take them through an imagination of walking to the particular chair. It's like a really comfortable chair to start with. Watching themselves moving down to the sitting position. Now the body's fully resting on the cushion, the back is supported, and there's a sense of calm and breathing, and they're just feeling this is a good position for me. Even while they're visualizing themselves doing it, their brain, in the process of sitting, that position is activated. So they're doing a motion for their brain on the virtual map that's not physically being done, but yet that stimulates the feeling of, hey, this is safe. So we have to break it down and find the ways to help a person overcome a sensation of fear and or pain for doing activities.
Yeah, I was working with a patient just this afternoon who was having hip pain when he walked on his treadmill. And it's one of the advantages of telehealth. We just got him on the treadmill and had him walk on the treadmill, paying attention to the physical sensations. And I kept asking him, like, how's it feeling? And he kept saying, well, the pain's an 8 or a pain's 6. I was like, let's move away from the concept of pain and just focus in on the physical sensations themselves. And he recognized that as he did that, walking on the treadmill became less painful for him rather than more. But afterwards, he said, it was so helpful that I was there with him. And so that's one of the big advantages as a physical therapist who understands this, is that you can sit with people as they start to do this, whether it's in their mind or in real life, and
Right.
you can walk with them as they practice this.
Yes, I love that. You utilize a beautiful technique that, a lot of our pain, our world in pain has a lot the same question. What's your level of pain? And there are apps that you will rate your level of pain umpteen times a day, and what you did, what you ate, and it's rating pain, rating pain. The research shows that's really not very healthy. I mean, to rate it once in a blue to give information to your physician if that person wants it, okay. But it's not natural for us to, it's not natural. It is natural for people in pain to think about it all the time. However, one must train your brain to move on to what does the fabric against my leg feel like? Or not to focus on what the sensation of my shoulders feel like right now.
Yeah.
So that will automatically will help the nervous system and brain shift gears. And so you can't think about the pain as much. So there's strategies. It's not like one fits all, but it's beautiful what you did.
Yeah, and you may not know this actually, but I looked it up one time. The phrase pain, the fifth vital sign, came out the same year that OxyContin hit the market. I'm just saying.
We're just saying.
Yeah. So anyway, so you work with people over time. A lot of your patients get a lot better. And so somebody who has, say, chronic urinary symptoms or painful intercourse, like, what does that look like as they start to improve? How do they know that they're getting better, and what do you see as they're improving?
Well, they're noticing less frequent symptoms. They're noticing, I had a patient who said that she couldn't drive from New York to Long Island without, literally, she would have to take a huge, TMI is not a big word in my kind of work. So she took a huge container of a Coca-Cola container, and she would pee in her car because she didn't want to get out of the car on the side of the road. She would fill this container because she had to pee so much. And as she got better, hey, I'm able to drive for longer. I'm not having to urinate, as much. So you can tell by the frequency, or if they're in pain, the amount of pain is less, or it's not as it doesn't come to them as a big huge threat over time, because they understand where pain comes from, and it's coming from the brain and nervous system still trying to do what it did for many months or years. So we have to train you. You're still in the training process, so I'm not going to freak out. I'm in a safe place. I'm being treated by, good physician and physical therapist. I understand the process. This is not like a line that goes up and up and up and up and up and always changes. It always gets better. No, there's lots of stops and starts. So the reaction that people have towards feeling discomfort or symptoms is a little bit less, which over time lessens as well.
Mm-hmm. And that's one of the lessons that I try to give out to patients as much as I possibly can, that one, there's ups and downs to getting better. And so any given day, it could be better or worse than it was the day before, but we're looking for the wide angle picture because we want to see the improvement, and that the improvement happens slowly. And so sometimes people, they're like 10% better or 15% better, and they get discouraged because they're not 30% better. And so trying to help people notice that these improvements are happening, and that if you can get 15% better, you can get 30% better, you get 30% better, you can get 50% better. And so continuing to stick with it and improve.
It's hard. It's the process of getting better is not simple. It isn't. It takes so much effort, and you have to give yourself time. I always tell people, you're going to give yourself 3 months. Oh my gosh, it's not going to be, you probably will feel some great shifts, but over the 3-month period, if you're practicing, and that's where the hard part is for patients. So we all want that one great manual therapy technique, or that one medicine, or that new surgical technique. I think medicines and surgeries are, if needed, totally go for it. But it's not the end all, because we all have, we know women with endometrial surgeries, IES, that are still in pain. Well, they don't need more surgery. It's a process of retraining their nervous system and brain. So I think we're such a fast-paced society. We want immediate answers. I think what we're learning in the healing sciences is that there are answers, and it's so exciting to see that. It'll just take that time you got to practice it and do it.
Absolutely.
That's the hard thing.
And I know we've got a big stack of questions that are lining up, and I want to get to those. I've got a few more questions for you, though, before we start to take questions from people who are listening. And so one, I'm thinking about sort of the calming the nervous system along with the manual therapy that you do. And a lot of our patients, a lot of people who are listening, have been to so many different practitioners, physicians, healers, and done a lot of work on the physical level. And they come to me, and they come to Curable, and they come to other practitioners in this field because it's such a breath of fresh air to say, I've got some different ideas. And like you, I have noticed that my patients with pelvic pain, oftentimes it requires some physical treatments also, in addition to the breath work and the calming, more so than, say, my patients with migraine headaches or back pain, who oftentimes are able to solve it just by using the power of their brain to imagine or interpret. And so let's talk for just a minute about kind of how to hold both in our head at the same time. And so there's this role for breath work and imagination and persistence. And I think with pelvic issues, oftentimes there's a role for the physical type treatments also. And so how do you really see those working together, and why do you think that combination works so nicely in this area?
Right. Well, I think as I mentioned, manual therapy really helps the nervous system and brain to be less fearful of touch and of function. I really can't say why pelvic pain patients might need more manual therapy versus spine or other types of chronic pain. Maybe it's because this has been such a embarrassing and shameful area. So there's been a lot longer years, maybe since childhood. We have to, of course, understand there's some sexual abuse issues that have occurred both to women and men. So, disgust about bathroom. There's a lot more holding and guarding and fear of the pelvic area. Maybe more than others. I really don't know. It's a great question.
Yeah.
So I think incorporating the movement to allow the area to, I had patients do try a happy baby pose, which is where you lie on your back and you grab onto your knees, a modified happy baby pose, and just bring their legs out to the side. And they were like, oh, how far can I go? Like, they were so worried that this is something that, will I have an accident? Will I hurt something? So I think the combination of manual and movement work will help to desensitize that fear and shame. that is so common around the pelvis.
Yeah, and I think that I tend to think of it as just an incredibly nerve-rich area when you think about sexual organs and urinary organs and
Yes.
bowel, just all the interaction and sort of all the input that's coming in
Oh
into
my
a
gosh, it's
small
such a,
space. And
right. It's a root of our system, all the sacral nerves, the reproductive system. It's so much vested in that part of our body that, you know, gives life. I mean, and eliminates,
Mhm.
I mean, enjoyment. So yeah, there's a lot. It's a great
Yeah.
point.
Yeah, and I think you're right too in thinking that like there's so much writing on this part of our body, and there's so much shame that frequently goes into it, depending on what people's experience has been. I hear that a lot from people too. Do you have any suggestions for people as to how to talk about this? I mean, it is more difficult, I think, to talk about, say, incontinence than it is to talk about a migraine headache. And so whether it's with health professionals or people in their circle, any thoughts about how to make it more comfortable for people to bring up this particular topic?
That is so great. You know, there are now some websites that are really promoting the research on why this area has been so quiet. I mean, there are 50 million women, 1 in 3 that will have some kind, this is American, some kind of pelvic floor issue. 50 million. I mean, women. So it is so normal. It is so common, not normal. It's really what I want to say. So I think, I mean, it'd be great if mothers and daughters can start talking a little bit about the functions of, I'm just talking about women, families can start talking about the natural aspect of our bodies, the educational aspect for our children is never on pelvic function. It's always sort of what's that, move on. So because where do we start? We start now. There are more organizations providing like products for women to develop pelvic strength, to, you know, to help release tension. There's more information coming out now. I think, I mean, I'm certainly happy to answer any of your viewers' questions about private matters, if that's something they rather reach out to. My staff is amazing as well. There are a lot of Facebook groups regarding pelvic health. Though it'd be great if they're more on pelvic health versus pelvic dysfunction. That's the thing. That's what I love about Curable, is more health related. So again, there are 50 million US women are dealing with this. Girls, when they go into menstruation, a good number of these young women start having pain with that. Not just like a day, but like a couple of days worth. That's not healthy. So these are things that I think there's more coming out. And I'd love this type of venue for that. So maybe we can have more conversations.
Yeah, no, yeah, really nice to have open conversations and open forum about this. So 2 last questions, and then let's move on to take some Q&A. One, so not everybody obviously lives in New York, can come see you guys in person. And even though I think you do some work at a distance, or your team does, and you can tell us about that, not everybody can access that, afford it. And so both, if people want to connect with you live in New York, if people want to connect with you from a distance, or for people who can't do either, do you have thoughts about what people can do if they don't have access to you, your team, or even pelvic therapists in their own area?
Great question. Well, certainly we have like some small ebooks that we've written about chronic pain that can give you an insight. There are some really wonderful websites about healing pain. Of course, Curable is a huge asset for that. And my practice is basically, we can do both coaching for pelvic issues, coaching because we are licensed in New York State, so we can't really do physical therapy for patients living out of state because we're not licensed in that state. That's just the way we roll in New York. So we can do telehealth for those residing in New York, and we can do coaching for pelvic issues outside. There are a lot of great pelvic physical therapists, and they're growing in number as well. So that's always good. And my practice is working on a few self-help programs, so that might be helpful as it is designed.
Mm-hmm. And how would people find you if they wanted to connect with you or your team?
Sure. So it's EMH Physical Therapy. So www.emhphysicaltherapy.com.
Great. And lastly, I don't want to leave out men. We've been talking a lot about women, but men have pelvic pain too. And I don't know the statistics, but I see a fair amount of them, and even sort of have experienced it myself on occasion. Mm-hmm. And so any thoughts about treating men, how that might be different than treating women in your practice?
Well, yes, men have pelvises too, and they can also become very wound up and create issues with erectile dysfunction, sitting pain, premature ejaculation, urinary urgency frequency. So I don't have the stats either, but I don't think they're minimal. I think men have been way more reticent to discuss this more than women have. So what I'm seeing now, which is awesome, I am actually seeing male physical therapists do pelvic physical therapy. I'm so excited because I know most men, well, we women can treat men, and we have. Obviously the anatomy, I mean, your little pelvises are so much smaller than the female. It was more narrow. And of course the genitalia is we have to know how to work around the region there, of course. But the focus is the same energy. Why we having these symptoms? What can we do to desensitize the tissue? How can we allow for more blood flow and some freedom of movement? Incorporate some breath work and stretching as well. So we do treat men and have great results with them as well.
Yeah, and I do think that you're right that it's it's oftentimes embarrassing for everybody, but it can be really difficult for men to bring up the issue, whether it's with their physician or anyone else. And then even when you bring it up, you have to be able to bring it up to somebody who can say like, yeah, that's common and there are really good treatments.
Right, exactly. And women get to see a physician, their gynecologist, and if they go every year, men don't do that. So they're even more tendency to keep things quiet and be.
So anyway, I said there's a big stack of questions that are lined up. And so let's take a few. Let me open these up. Belief. So number one, how do you overcome the belief that this will never get better?
Well, that is a belief that you're currently, your brain has developed. It's learned this, understandably. And the science shows that our prefrontal cortex has been sleeping because the amygdala, the midbrain, has been on high alert and running the show. So how can we reverse the belief is by starting to do some of the work, the mind and body work, and practice over a few months to train the brain and nervous system to have a different belief, a more functional one. So that takes time, it's doable. So that's my answer.
Yeah. And I advise people too, oftentimes to sort of track things over time. And so like I said, taking that big picture approach, you have to be able to notice the small improvements, because if you don't notice the small improvements, then you can't get to the big improvements. And then I talk a lot about this concept of outcome independence, which is big in the curable world, and our colleague Ellen Gordon in Los Angeles, but focusing on the important things. And so even if you're not necessarily seeing an improvement in the pain, or you're not sure if you can, what are the things you can control? You can do your breathing exercises, you can do your visualizations, you can do your home exercises with the stretching. And so focusing on, are you doing those regularly? Because as you do those regularly, oftentimes you do start to see the improvements. And so focusing on the things that we can control oftentimes starts to influence the things that we sometimes feel like we have less control
And that
over.
gives us, that helps us develop that new belief, the healthier belief.
Yeah.
Yeah.
So the next question, when the symptoms are so bad, your pelvic floor is on fire, you have frequency all the time, how do you become indifferent to the symptoms? Like, how do you not assume that this is an alarm that you need to address?
Right. Well, I always want to make sure that women, I'm going to be specific, if one is having vulvodynia or vulvar types burning symptoms, one must go to see a top tier, knowledgeable sexual medicine physician, because it's not just the mind and body work. Sometimes it needs the treatments of the hormones or the capexin treatments to change the nerve firings or the type of substances that are produced. So it's a combination of both. It's very hard to ignore high levels of symptoms. So if you're seeing a good sexual medicine physician, I highly recommend the organization. It's ISSWSH, the ISH-WISH.
ISSWSH. Okay, got it.
Yes, it's international studies for women. I won't get into, I always get tongue-tied. So ishwish.org is an amazing organization of physicians and other health professionals they really focus on these issues and they're all over the country. So highly recommend that there's good medical care.
And so it really is this biopsychosocial approach. Like, there's a role for all of that. There's a role for the breathing, and there's a role for the imagery, and there's a role for the stretching, and there's a role for medication. Like, it doesn't have to be just one, or it doesn't have to be all this way. It doesn't have to be all that way. And then when people really find a team and an approach and a combination, that oftentimes when people are stuck is a potential way forward.
Yes, right.
What if it's been going on for decades? Do you find that it's harder to treat than if it's relatively new condition?
It's a great question. I've learned that it takes about 3 months for people to really reverse or start seeing the difference of symptoms with practice. So just because one is 88 or 28, 10 years of something at that age or earlier, the body does shift, the brain shifts. We can learn things until we die. We have the brain has the ability to learn new things, new languages, new experiences, practice new ways of functioning. So I wouldn't limit the fact one has had this situation for that long a time to be a deterrent for let's move forward.
Yeah. And I see that, some of my patients who've had symptoms for decades respond actually quite well and quite quickly sometimes. Yeah. And so I don't necessarily see a correlation between how long the symptoms have been there. Somebody asked again about the prefrontal cortex loss. Does that always happen, they said, with people who have chronic pain?
I think in the research, it does show that there's atrophy of the gray cells of the prefrontal cortex. The longer somebody is having, or even after the 3 months or 4 month period, that does occur. Mm-hmm. So the good news is that as you practice the process of self-healing, and of course, if you're seeing good physicians and you're doing your manual movement work, that the gray matter can grow back and can spark more, and you can quiet that lower midbrain, amygdala from its overabundance of alarm bells ringing. Yeah.
This is a more extended question, so I'll read through it. So I had pelvic pain for 2 years, constant life-altering. Pelvic floor PT helped, but not significantly. But then I got off birth control to have a child, and it got better by like 90%. Still get occasional flares, but it's much better. Do you see this often? Do you see a correlation between birth control pills and pelvic pain?
Wow, that is a great question. That's why I always say to my patients, women patients, is to go see a good sexual medicine who will take, or gynecologist who will take a real good look at your hormone. There's a lot that I don't really know about how much hormones play, how much of a role hormones can play, but they do play. And we have to look at it because we have hormones. So that's why I want my patients to see a gynecologist with that specialty.
And I've seen, interestingly, what I see is that birth control pills cause symptoms and cause side effects often enough. And maybe it's a small amount. There's a lot of women who are on birth control pills. And so in absolute numbers, it's a lot. My experience with OBGYNs is oftentimes they have it in their mind that they don't cause symptoms. And so when people are having them, sometimes it doesn't get recognized. And so what I say to my patients sometimes is, I've seen enough to know that birth control pills can be the problem, no matter what the problem is. So I've seen a number of different conditions that have responded well to getting off birth control. One of my patients one time, her libido was low. I think we were trying to treat that. So we took her off birth control. And she said, it's interesting, like my libido's not that much better, but I don't hate my husband anymore. And so like it can cause changes in people. And so I've seen that. And so it's always one of the things that I think about when I see somebody who's on birth control, whether we're talking about this symptom or others.
Yeah.
What about clothing? Any thoughts about how that affects pelvic floor function? And this says, I don't even understand what this means. Do you have any thoughts about how many women are always sucking in?
Well, girls, it is a fact of life that most women don't like to have any kind of little teeny tiny little anything on their pooch, on their belly. It's just our society. But it's not healthy to be sucking in. When you suck in, you actively are pulling in your transverse abdominis, which is the lowest and deepest muscle of your front abdomen and side abdomen. And you're also contracting your pelvic floor muscles. No. That's not healthy. So yeah, I will say sucking in is an issue. Because you're basically saying, okay, muscle, you should be like a tight fist all day long. And over time, that all day long it becomes 24/7. Those pelvic floor muscles are tight all day and all night without you realizing it. So try not to do that. A little pooch is okay. It's sexy.
So this question is another extended question too. Some of what we were talking about earlier, how do you combine the mind work with physiotherapy work? And so if you're thinking that like you need to be doing one or the other, and so this urinary urgency this person has and started during straining, but has done a lot of physical therapy and then has done a lot of psychological work, still not improving. And so how do you hold those both in your mind at the same time? There's a role for each of those in the overall healing.
Yeah, without me knowing not exactly, but close to, when the person says a lot of psychological work, does that mean they went to see a psychotherapist?
Probably, or doing some of the things that we're talking about,
Okay.
The relaxation and the breathing and sort of focusing on the mind aspect.
Right. So it's hard for me to answer this question, though what I do like to say is to do both at the same time is good. Many still, not all, but many physical therapists are still not incorporating the mind work with this type of healing. So they may have, without unwittingly, may have given you mixed messages. The best thing would be to like, okay, I'm gonna focus on doing both my physical therapy related exercises and combine with my mind work and also the strategies I was taught when I feel that urinary urgency come in. There are definite strategies for decreasing urgency. Maybe if you haven't learned them, you can ask your therapist to teach you what they are, because then that will give you something to go forward while you're doing the classic exercise and good mind work.
And so you're practicing the strategies on a physical level while you're training your brain to calm down the whole system.
That's right.
And,
yes.
and that together sometimes is the solution.
Yeah.
How do you know if the root of the problem is at the pelvis? Is there certain things that you look for to help people understand that that's where they should target their treatment?
Right. Well, certainly, if we find that if we see a patient with symptoms, and we'll assess the breath work, and they have beautiful ability to breathe. The pelvic floor contracts nicely, strong, relaxes, goes to its healthy resting rate. We test a resting rate, something through biofeedback, which is basically measuring the electrical current of your pelvic floor muscles. So this gives you and I a good objective data. A resting rate of a muscle should be at 1 microvolt, for example. It's the amount of current, electrical current in your muscles. And you should never have a 0. That means you're dead. So either it's 1 or 2 microvolts. Is a biofeedback showing us that? Do you have good flexibility and good overall strength? And your tendency for positive affect is higher than a negative affect, and you're doing some of these already, some more being grateful, small techniques that can help your brain focus on the positive. If you're doing all of that work, then those are really, really good. I've sort of lost the train of that question. What was the question again, John?
It's how do you know, like, what are the signs you should look for that the problem might be in the pelvis?
Right. So if we're seeing all of these, the problem is not lying in the pelvic region. Yeah. Not that we can see or we can palpate. So we have to rule out if there is, and we typically can find some strong objective data findings. If we don't, then it's not within it might be a GI related issue completely and nothing to do with the pelvic floor or the tension within the lower abdominal region.
Yeah. Let's see. I have this next question. I have vulvodynia and interstitial cystitis. I work really hard to believe this is a mind-body disorder, but I get tripped up. So the IC is bladder filling pain and increases in pain and symptoms at certain points of the cycle. So that makes her hard to think that it's not a physiological and hormonal part of the condition. Any thoughts about how to strengthen that belief or understand the role of the mind when it feels so physical and so many signs point in that direction?
Absolutely. Well, if she's seen a good physician that is monitoring the hormone balance, that's really key for a lot of these vulvodynia related issues. What I've seen with IC and IBS, there is so much of that elevated sympathetic nervous system activation. So I give a lot of parasympathetic type exercises, and also I want to make that pelvic floor and core like functioning well, like strong and flexible, so the pelvic floor and bladder can better talk to each other. She's asking a great question, but it feels like I need a little bit more in-depth information from her for me to really say, oh, this is what you do, because I don't want to be so flippant as saying that.
Yeah. Well, one of the things that I say too is that, like, there's always a mind component, there's always a body component. And so we don't necessarily know in the beginning how much is what. And so work on one side and work on the other side. One of my patients who's done really well, say with migraine headaches, she came to me initially, she's like, I want to be 20% better. She's getting 200 headaches a year and wanted to get to 160. And she got down to 2. So she got 99% better. But she didn't know that at the beginning. And so I say, pull in the mind side, do the relaxation, activate the parasympathetic system, decrease the tone, and you'll get some improvement. Very often you get more improvement than you would have imagined, especially at the beginning.
Wise words, John. Thank you.
Any thoughts about food and its impact on pelvic or bladder pain?
Yes. if you're going to eat Twinkies and drink Coca-Cola, if you're going to eat tons of processed food, there has been too much research out there now saying that that could be an inflammation process, which can affect all these pelvic floor disorders. So a lot of good nutritionists are guiding you individually. Certainly they start with carte blanches, doing like a gluten-free. Just take out all the gluten for a little bit of time, see how you feel for like 2 or 3 weeks. And then you can add add back one of those items you took out for another 2 weeks, see how that makes you feel. So there is a nutritional aspect. We just can't take out the body, mind, nutrition. Nutrition is so important to feed us feed our microbiome, to feed our gut well, to help our immune system. So if you're eating a lot of, takeout foods or processed foods, not a lot of healthy type foods, you might want to consider, I'm being very general, but you might want to consider incorporating some of that. Your diet has a lot to do with your immune system.
I agree too. Sugar, I think, is another one that really can come out both in urinary symptoms and like I said, I occasionally will get rectal spasms or pelvic pain. I think the last big one was after too much birthday cake. So yeah, I have noticed that correlation over time.
And you know how much sugar I think women are supposed to only have like 5 to 7 grams a day. And you do one Starbucks, like a sweetie Starbucks, we're talking like 18 grams in a drink. So we eat way more sugar than we think we do.
We do, and we eat way more than we ever have in terms of human evolution. And all right, this one of my patients, actually, she and I talked about this yesterday, and so I'm glad that she remembered to ask the question. So long-time hip pain, hip flexors, inner thigh, piriformis, glutes. Her husband died a few years ago. And so sexual health is by masturbation at this point. And orgasm doesn't create pain. But then after she gets up, strong piriformis, groin, and inner thigh pain. So the mind-body approach has worked in a number of situations, but she's less clear about what's happening here. And I know a number of my other patients say the same thing, that they have this pain that's associated with orgasm that doesn't make sense. Like, what in their mind would want pain then? And so any thoughts about pain that shows up after sexual activity, whether it's with a partner or on one's own?
Obviously during orgasm, the pelvic floor muscles go through a strong and very quick rhythmical contractions, very strong. And one of the reasons why women may be experiencing post-sexual activity pain is because the pelvic floor, either it does not go back to its normal resting position, and it's still a little bit on high tone. And so all the girls around her are also have on high alert as well, high tone. So one of the suggestions I would do is post-orgasm, you can put some warm compress over the area or cool, whatever makes you feel good. And then do some gentle breathing and maybe some stretching of the area, a little bit of that versus coming right up and out of the post-orgasm.
And so go ahead.
It just might be something you can do to allow muscles to go towards resting. They might need longer time to get to a resting rate than.
So proactively going after it and saying, and that I think is, we can have in our minds, like, this should be a pleasurable experience. And so I don't want to do anything afterwards that sort of disrupts that or takes away from it. But you're saying that, like, especially if the area is tight to begin with, it may just need some help after that experience, even if the experience is pleasurable.
Yes. And then I would work on, obviously if there is a little high tone happening, I would work a little bit on some techniques to soften and lower the pelvic floor a little bit throughout the day, like 2 or 3 times throughout the day, just softening. And where's my pelvic floor? Can I lower it as I talk and as I speak to you now? Can my pelvic floor relax? Yeah. So, without realizing it, a lot of people tend to have their pelvic floor a little bit on edge all day long. So by tapping in, like maybe once every 2 hours, set your phone, a little ding, and then where's my pelvic floor, and then soften it and do a few breaths and then move on. And that way we'd like you not to have to stretch after you have an orgasm. Yeah.
Yeah. Next question. I'm 77. I've had pain for 10 years. Is it too late?
Girl, no way. There is no too late for any of this, especially if you've never done any work for healing. The body loves to move. The brain totally enjoys healthy movement. So there is no time limit to healing.
I agree. Let's see. I've been in pelvic pain for 15 months, done PT, went to a lot of people, including the Wise Anderson Clinic in California, made some progress, but then it wasn't as much as she hoped. So she slipped into depression and anxiety and can't get out of the fear cycle. Any thoughts about how to sort of manage the despair that comes when you're not improving as much as you like or as quickly as you like?
Yeah, that's a lot of what people want. They want a good result, and if they don't get it, then it's like that the tongue rolls back into the mouth, like, well, I guess I'm not going to get better, and the brain says, oh no. So that there's a strong pattern of depression and anxiety with women with pelvic pain. There's no question.
Yeah.
What I would suggest would be to get back on the horse. I'm not trying to be snarky or funny, but it's all about, we've got to have more time to retrain your nervous system and brain, and to be less hard on yourself and to be less critical. Criticism is like it's like taking a whip and lashing it on yourself. Criticism is the opposite of self-love.
Yeah. I've been saying that to people lately too, that I think the more I study this, the more I think we can be critical of ourselves or we can heal, but oftentimes we can't do both. And so trying to give ourselves space and grace and time and compassion, and sort of keep moving at it, keep working at it. And
there's some really wonderful, great meditations on YouTube, or if you want to get one of those, of course, curable. What are we talking about? You listen to some self-compassion, self-love meditations. These are good to go back to elicit. I need to take care of myself. I have to be gentle, and you will get there.
Let's see, a couple more questions that are here, and then we'll wrap up. Do you certify pelvic floor therapists, and can you vouch for their ability? Persons in DC and wondering how to find somebody who's trained in both manual therapy and brain health, brain training.
Oh, both brain psychosocial work?
Yeah.
Okay. A lot of, you can find great pelvic physical therapists through there's a Herman and Wallace website. They're a big educational organization that teaches physical therapists to become certified pelvic physical therapists. The American Physical Therapy Association is another organization, their pelvic health section. They also teach for pelvis. The biopsychosocial world is still kind of young for physical therapists, but a lot of pelvic physical therapists are embracing it because the information has been brought out to our organizations. So a lot of us are learning that. The young ones, the young therapists are definitely learning that as part of their approach to care. So I think if you went to these websites and called people in your area, Washington, DC must have a lot of really good pelvic physical therapists. And you can ask those questions. You have a biopsychosocial approach.
Yeah. I got a huge flare up after PT, and my therapist said because I had resistance to healing, even though I really want help. Have you seen that? And do you think that sometimes people do resist the improvement?
That's a good question. My sense is that most people do not have a resistance to healing, unless it's so rare though. It's like 1 in a million, I think, where a person likes to stay ill because they get attention. I've heard that 1 or 2 of my patients said that.
Mhm.
It blew me away.
Yeah, I've seen it sometimes, not in that. And so I try to really move away from this idea of secondary gain or people are trying to get something. But I think, we're complex as human beings, and there's always some resistance to change, even if that change is for good. One example that I saw, and sometimes I'll ask my patients, like, is there anything that the pain does for you or shows about you that's really good? And so one of my patients, this is a hard one, she's having pelvic pain with intercourse. And when we really got down to it, she and her partner had had sex every single day for the 5 years that they had been dating. And I think it was just too much for her. And so it was her body's way of saying it wanted something different, but without sort of having the verbal language to say that within the relationship. And so sometimes I think that the pain is providing something for us that we have to calm down and listen to. And then the better we can listen to it, the better we can address it and get it to go
That's
away.
beautiful. Mm-hmm.
So last 2 questions here. People who experience trauma due to the mistrust of physicians and multiple physicians and haven't seen results, and so many different diagnoses and types of treatments, including medications. How do you regain trust in the medical system so that you don't end up just depressed about this all?
Well, most medical physicians haven't learned, first of all, they hardly have learned what pelvic physical therapy is. I certainly had to do a lot of education, and it starts in the medical school. No fault of the physician. It's just what they haven't learned. And they are not learning now yet about the biopsychosocial approach to healing. So it's understandable that your good intention was to find due diligence and see physicians who are specialists to see if they can help you. Most physicians are looking for the biomedical cause of pain, which is what they're great at. But if it's not a biomedical cause, then the other biopsychosocial causes has to be looked at as well. Mm-hmm. Yeah, it's a great question. How can you gain more trust in your health practitioners? You can call and start talking to ones that might have a similar outlook. You can find health practitioners that have a biopsychosocial approach. There are, so it's not that we're not around. There's plenty of them. Yeah. It just takes a little sleuthing depending on where you live.
Yeah. I've had pelvic pain for 13 years, happened after bladder prolapse surgery. PT tells me I have ropes of scar tissue and she works on them and is awful. Could the scar tissue contribute to the pain?
That's a great question. That's a great question. Part of me says maybe, because of course, if you're having tissues that are not pliable and functional, that could be, tethering and creating discomfort, of course. So that's, that is such a great question.
Yeah. I hear this from my patients. Do you have to go through pain sometimes in the manual release in order to get relief? Because I hear that from my patients that they've been to physical therapists and it's just, it's excruciating. And so is that part of the process?
No, I've learned that that's not helpful. Unless a person it likes the deep work, it makes them feel I'm getting something done and it makes them feel good. I will do that because I want their nervous system and brain happy. Yeah. But I'm not going to sit there. Okay, girl, here's a stick, write on it as I work on you. Absolutely not. They are already in pain. And my interest is to soften and desensitize the nervous system. Mm-hmm. So whatever I can do that way. That's
Yeah.
our approach.
And last question, somebody had just typed in about trigger points. Is that something that you work on either internal or external? I know that that's a big topic that
Yeah.
people hear about.
Yeah, you know, I grew up in learning all about trigger points and travail and all that stuff.
Mhm.
If trigger points were the answer to things, then everything would be fine after a trigger point release, but that's not the case.
Yeah.
So I don't use the word trigger points anymore. I'd like to use let's get your nervous system to send more dopamine. Let me do a technique. Let's see if it will become softer. Oh, good. That means that you've gotten more dopamine to the area. Or yeah. So
Good. All right, I kept you on long. I apologize for that, but thank you for sticking around till we got through all the questions. Any last tips for people who are listening and have stayed with us this whole hour and a half in terms of continuing on this healing journey?
yeah, well, you know, it is so exciting to see final proof that the brain, the immune system, and the nervous system has the ability to shift a pattern that it has been in. So find the health practitioners that you love, whether it be a massage therapist, an acupuncturist, Dr. Starks, anybody that you feel I can have a great therapeutic alliance. Do your exercises, your mind work, and your body work, and take whatever medications you need so you can get over the hump, so you can start to have a better quality of life. Um, I've seen people do some incredible changes and improvements in their lifetime. 10 years of not being able to sit and play the piano and earn a living, back to sitting and playing the piano and earning a living. So it's doable. It just needs practice and bringing up a new belief that it's doable and it's possible. So I would continue on the path of healing because it's doable.
Yeah, and one more time, if people want to get a hold of you or your team, how can they do that?
Sure, they can email us at, go to our website at emhphysicaltherapy.com, and our email address and phone number is there.
Great. Thank you so much for being here this evening and talking about it and answering everybody's questions. I so appreciate you, and I know how much people who are listening have appreciated it.
Thank you so much for having me, John. I appreciate it.
You're welcome. And so thank you to everybody who's been here and listening to us talk this evening. Every time we do this, I'm proud to be part of this community of people who are brave enough and insightful enough to think about pain in this way. As I said earlier, I am available for remote consultations as well, whether pelvic pain or otherwise. You can go to my website, www.drstracks.com. And if you enjoyed this episode, you can find our previous episodes at Curable and my Hope for Healing landing page, which is curablehealth.com/hope for healing. You can sign up for either one of our newsletters and get updates about next episodes and everything else that's going on in my practice in the curable world. I will be back in 3 weeks on Wednesday, March 10th at 4:30 Central Time with another episode of Hope for Healing. So I hope everybody can join in. And until then, I hope everybody stays safe and healthy and has a good evening. With that, we'll say good night.
Good night. Thank you.